loss of the disc rim. We can look at rates now with quantitative imaging, and we have these three techniques, of course. Most of what I'm going to talk about has to do with HRT and confocal scanning laser ophthalmoscopy, where the techniques for developing measurements of progression are probably most well developed. We have event-based methods to detect change, such as with topographic change analysis, so-called TCA, which is a probability analysis with pixel distributions and in which the spatial information is preserved. We can also apply trend-based analyses over time, in which we look at summary structural parameters and regress those over a long period of time. Typically, a rim area is used, or you can use cup-shaped measure, or one can use combined measures to look for change over time. Let me show you a few examples. This is from a paper that Chauhan and my group and Joost Jonas have collaborated on, looking at the comparison between measuring progression, looking at the optic nerve photographs compared with sequential HRT analyses using the TCA analysis. And on the left, we see an example in which all the observers agree that there was clear evidence of progression of disc change that you can see there quite clearly. And over this period of time, there have been a number of serial HRT images, and one can see that the TCA also picks up this change. And even though this is a sort of an event-based analysis, one can deduce some information about rates if you have enough images over time. On the right is another example in which observers did not agree that there was progression with respect to the stereographic optic nerve photograph. But if you look at the TCA, it looks like there is clear evidence of progression, sort of in the right place, at the right time. It develops and persists. With respect to trend analysis, here's an example of rim area changing over time in sequential photographs over a period of about 6 years. This next example is one I pulled from the literature. This regresses a series of cup-shaped measurements over a long period of time. And that red line indicates where the visual field became abnormal. This was an ocular hypertensive patient who was followed over a period of about 8 years or so. So some information here about rates. One can do similar things with scanning laser polarimetry. And here I show you the results of a paper by Medeiros and co-workers looking at a group of glaucoma patients and suspects who were followed for a period of time and looking at their change in the scanning laser polarimetric measurements of nerve fiber layer thickness. And we can see with the blue line that there has been in those patients who have shown evidence of change by other techniques, that is visual field and disc, that there has been a significant thinning over time of the nerve fiber layer. And again, it's at the superior and inferior poles of the disc where you would expect it. This is compared to the red line, who were the non-progressors in their group. This was a nice example that Felipe showed, showing the development of a nerve fiber layer defect inferiorly that you can see on the photographs, and you can see it in the SLP scans, as well as the visual field. With OCT, one can do a similar thing. This is a nice paper by Lee and Kyo Park from Seoul, who showed the ability of OCT to detect progressive nerve fiber layer defects. Here you have an example of a widening nerve fiber layer defect over time. And they, in a group of patients, showed that they were able to detect this progression. And these areas were most frequently detected where you would expect them at the inferior temporal and superior temporal poles. One can use this sort of data to develop race, although this hasn't yet been done. What about rate detection with respect to function? Well, the problem with rate detection for visual fields is mostly what we used to call long-term fluctuation or intertest variability. There's an inadequate sensitivity and specificity of these tests, and there's a classical signal-to-noise ratio problem. This requires multiple tests in an effort to try to average out the noise, confirmatory tests to validate the signal. And one of our problems here, of course, when we're comparing different methods to measure visual function change, is that there is no lack of external validation. Remember the lack of synchronicity between structural change and functional change. We can apply also trend and event analyses here. Trend-based analysis such as point-wise linear regression or PLR. We can cluster these points, or you can use the whole visual field in which we wind up with a regression of visual field indices, which has its benefits and its drawbacks. One can apply an event-based analysis such as the glaucoma probability analysis or scoring systems such as were used in the AEGIS and SIGITS trials. The advantage of trend-based analysis, of course, is that it gives us information about rates. However, it requires many tests to develop a robust estimate of the rate. With event analyses, we require fewer tests in general to reach a decision about change, but there is perhaps not no information, but little information about rates. Both of these techniques require some evidence of persistence of the effect or confirmation of the change. You know about this, the glaucoma progression analysis, and we're looking down here and follow up for these solid triangles which indicate persistence of change in 3 or more consecutive tests. And in this patient who appears to have on that basis some progression in the superior field, we are able to validate this patient by showing a consistent change over the same period of time of their optic nerve. When you can, this is certainly well worth doing, but it's not always possible depending on the stage of the glaucoma. If it's very early or very late, this kind of validation is usually difficult. This approach, however, while it's certainly clinically useful, gives us no good information about rates. I want to review a paper recently published by Bengtson and Hale using what they call a glaucoma progression index for measuring rates. It's certainly a step, I think, in the right direction. It's normalized to the entire range of visual function from normal to at least parametrically blind. It's actually based on the pattern deviation plots in an effort to get away from media-related effects on the visual field. It's weighted centrally to give more weight to the more important central portions of vision, and also provides some element of prediction of what might happen to this patient if their course was unchanged 5 years later. This is an example from their publication. This is a patient who has both cataract and progressive glaucoma. On the bottom here, we have a regression of simple mean defect. And on the top, their glaucoma progression index. And their point here was that the glaucoma progression index showed a lower slope because it was less affected by progressive cataract in this patient, which was picked up by mean defect. And mean defect certainly is a good way to detect progressive cataract parametrically. One can rather look at individual points rather than the whole field. When we look at the whole field, we're likely to miss localized defects that might be important to the patient's function and to their disease. And so regressing sensitivities in a point-wise fashion is something that can be done, and I'd like to share with you now. Here's an example of a patient who's had these 20 visual fields starting at the top left and the last one at the bottom right.